All right, so I'm going to convince y'all that PMR is the way to go to treat this patient. So patient, as stated in the brochure, there's a 51-year-old male, weekend warrior, slightly obese, BMI of 33. So that's our typical male, slightly obese patient. He had radicular symptoms that initially resolved after, of course, some PMR, so with some medications, an epidural steroid injection, and some physical therapy. So he's had these symptoms for about 3 months. So just briefly looking at lumbar transfemoral epidural steroid injections. This was a study that looked at lower lumbar TFESIs that were done for radicular pain secondary to disc herniation causing lateral recess or foraminal stenosis. And responders were defined as anyone who had greater than or equal to 50% pain relief and or greater than or equal to 40% relief in or improvement in function. So our patient is in that category of the 60+ percentage who have done well after an ESI at that 3-month mark. So this is just a fluoro image showing a left L5S1 TFESI. So that's targeting that left L5 nerve root. And I mentioned physical therapy as well, so shout out to all the physical therapists. My wife is one of them right there. She's in the audience. So this study here looked at performing a TFESI to help control the pain and then enrolling the patient into a formal physical therapy program. So this looked at 70 patients, did one TFESI. If their pain was under better control, then they participated in a comprehensive physical therapy program, and almost 80% of those patients avoided surgery at the 1-year follow-up. So that's where our gentleman is right now. He's still having axial low back pain. It seems facet-mediated on exam, worse with extension and twisting, so AKA loading the facets. So that's the terminology we need to put in our notes for insurance to approve these facet innervations. Even though we know that these maneuvers don't really correlate with facet-mediated pain, the only way to prove the pain is from the facet joints is by performing diagnostic medial branch blocks. So the facet joint has been thought to be a pain generator as early as 1911. And in 1979, Dr. Bogduk and Long detailed innervations of the facet joints and established the current practice of RFAs. And so these pictures here just show the medial branch branching off the dorsal ramus, and it then innervates the facet joint and the multifidi muscles. There's also the lateral branches and the intermediate branches that go to some of the cutaneous areas as well as some of the other paraspinal muscles. So medial branch blocks, they are validated and shown to have therapeutic utility, and so therefore they can be used as a treatment. So this is a nice schematic just showing the medial branches innervating the facet joints. So each facet joint is supplied by 2 medial branches. So for example, the L4-5 facet joint is supplied by the L3 and the L4 medial branches. So on the bottom there's a fluoro image of a right L3 medial branch, so the anatomy there is at the junction of the SAP and the transverse process at the L4 vertebral body. And so you may have noticed that some insurances are denying intra-articular facet joint injections as a precursor to RFA, and that's because those injections are not considered diagnostic. So because when you do an RFA, you're actually targeting the medial branches. You're not doing anything into the intra-articular facet joint. And so that's why they want us to order more medial branches instead of intra-articular facet joints. And also with facet joint injections, you're using steroid and sedation, and that can confound the results, and they're not really considered diagnostic that way. So how I perform these, I use anesthetic, usually bupivacaine, perform the medial branches, the patient then goes home, tests their back out, so reproduce different maneuvers that usually replicate their pain. We talk the next day if the patient had greater than or equal to 80% relief for the duration of the anesthetic, so that's usually about 4 hours or so. And if they do that on 2 separate occasions, then they would be a good candidate for a lumbar RFA. So the RFA needles, they have these electrodes at the end and they coagulate the medial branches, and so that prevents any of the pain, signals from those facet joints. So that's just what the RFA electrodes look like. And you burn those nerves for about 80 degrees Celsius for 90 seconds, so it's about 175 degrees Fahrenheit. And the reason why those parameters are used is because those settings are what gives you the best lesion size without causing any tissue destruction to any surrounding structures. And so in patients who had diagnostic relief of medial branch blocks, 70% of those patients had at least 50% relief after the RFA, anywhere from 6 months to 2 years or so. The average duration is about 12 months. And yes, those nerves, they regrow and regenerate, so the pain can come back. If it does come back to the point of wanting to repeat the RFA, then you can go straight to the ablation. You don't ever have to do those test injections again. So this is a simple procedure. People do well with them. Minimal downtime. Patients can go back to work the very next day. So these are just fluoro images showing needle placement for lumbar RFA. And that's it. I have spoken. This is the way. So.